So here we're going to talk about medications that are your calcium channel blockers. In general, your calcium channel blockers, or your CCBs, are going to be used for one of three conditions: angina, and arrhythmia, or hypertension. This is due to the fact that calcium is actually involved in both electrical as well as mechanical events across the cardiac cycle, and vascular regulation and smooth muscle as well. General properties of your CCBs include the fact that they are lipid soluble, they tend to be rapidly absorbed, they bind largely to proteins, they're metabolized by the liver, and they generally have low bioavailability. Now, all of your calcium channel blockers inhibit the L-type calcium channel on your vascular smooth muscle, your cardiomyocytes, and your nodal tissue. What this then means is your CCBs can cause negative inotropy, that is, reduce the force of contraction, negative chronotropy, reduce the rate of your heart, and reduce the velocity of your heart. It's important to note that CCBs generally do not change your serum calcium levels. So you can't just monitor CCB levels by looking at electrolytes in the blood or plasma. Your CCBs have two general classes: your non-dihydropyridines and your dihydropyridines. Verapamil is one of the non-dihydropyridines. We use it as an antiarrhythmic. It is a class 4 antiarrhythmic. It comes in both IV and oral forms, and we tend to use it for things like supraventricular tachycardias, particularly in the IV form. In the oral form, it's used more for hypertension, angina, atrial fibrillation, paroxysmal supraventricular tachycardia prevention, tardive dyskinesia, etc. There are adverse effects or side effects of verapamil. Constipation is perhaps the most common one, but you can also see headache as well as gingival hyperplasia. Diltiazem is your other non-dihydropyridine, which again is a class 4 antiarrhythmic. And these are again going to be generally used for arrhythmias like paroxysmal supraventricular tachycardia, atrial fibrillation, or atrial flutter. However, you can also use diltiazem for things like angina and hypertension. When using diltiazem, certainly one would be wary of the side effects that include things like headache, particularly edema. Moving on to your dihydropyridines, there are multiple generations of these calcium channel blockers. Nifedipine being your first generation, which is generally your short-acting calcium channel blocker. Your second and third generations tend to be a little bit longer acting. Nifedipine can also be a cardiac depressant, whereas your later generations tend to have less of a depressive effect. Second generation dihydropyridines include Nicardipine, Nicardipine, and Amlodipine, and your third generation dihydropyridine includes Amlodipine. Now, nifedipine works by inhibiting your cardiac and vascular smooth muscle contraction, so in essence causing less contractility, less work by the heart, more vasodilation. You're also going to see decreased peripheral resistance because of that vasodilation. It typically is used for things like angina, hypertension, pulmonary hypertension. It's an off-label use for Raynaud's phenomena as well as anal fissures. The side effects of nifedipine include peripheral edema, dizziness, flushing, headache, heartburn, and nausea. Isradipine, again, inhibits the cardiac muscle less than your previous generations, but it does have that inhibition of the vascular smooth muscle contraction. So again, causing vasodilation and decreased peripheral vascular resistance. Really the only use we typically see with isradipine is for hypertension, and it can cause, as a side effect, headaches, edema, and dizziness. Nicardipine also causes the vasodilation. Its uses generally include hypertension as well as with patients who have chronic stable angina. It can too also cause a headache, flushing, and peripheral edema as side effects. Now, Amlodipine actually has no cardiac depression, so it's purely through vasodilatation that we see its effects, which can be useful, again, for things like hypertension or chronic stable angina. Side effects of Amlodipine include headache and peripheral edema. Amlodipine is another dihydropyridine, the benefit of which is that it tends to be very long-acting. Also, it doesn't have that cardiac depressant that we talked about. And in addition to the vasodilatation that causes the decreased peripheral vascular resistance, it can actually also increase your myocardial oxygenation delivery in patients who have vasospastic angina. So again, uses can be things like hypertension, angina, or coronary artery disease. Side effects of amlodipine include edema as well as pulmonary edema. Nimodipine is the last dihydropyridine that I want to talk about. Just very briefly, it's important to note that nimodipine can be useful in the sense that it can cross the blood-brain barrier, therefore prevent cerebral vasospasm after something like a subarachnoid hemorrhage. Now, overall, CCBs have some general contraindications that you want to be aware of. First of all, if a patient displays any hypersensitivity to CCBs, certainly you don't want to give them another CCB. If a patient has a second or third degree heart block, both Parkinson's white syndrome, sick sinus syndrome, also be wary of giving them a CCB. If they have symptomatic hypotension, certainly don't want to give them something, again, that could cause further hypotension. And finally, CCBs, especially your non-dihydropyridines, should not be given when you're giving a beta blocker because of the effect on cardiac electrical and mechanical activity that we might see exacerbated when combined with the beta blockers.